Okay, so we'll get going with the panel, and the way we do it is sort of I throw some questions out and get a good discussion going, and then we'll migrate to the audience to ask questions. And you know, the first thing that I want to throw out there, and I see a theme, and the theme that I've been hearing today is early diagnosis. That's you know, there's different ways to address that. There's different ways to attack that, and there's still a lot of hurdles. So, what are sort of the biggest hurdles in get early diagnosis going? I mean, I see lots of initiatives, but there must be hurdles, there must be struggles, and you know, I've seen people nodding their heads. So, Sylvia, do you want to take a stab at that question, early diagnosis, as the first one? Yeah, you go first, and then we'll hand it over to the others.
So the challenge with acromegaly.
They may need a microphone.
I just got informed that you need the mic too, and then.
You hand it over, yeah.
I'm gonna be back and forth, so that.
We can come up and talk here if that's
No, it's okay, don't mind. I need to lose a couple pounds.
Yeah, this is an exercise program. So one of the challenges with acromegaly. There, now is that on?
Yeah.
So one of the challenges with acromegaly is that it's a very slow, insidious progression. And the things that patients manifest are common. When they're common and they're not always associated with acromegaly. So people get carpal tunnel syndrome, people get sleep apnea, there are many reasons for that. And one of the things that we know is that, and this was said I think earlier, that when you see somebody every day you don't notice the changes. When you don't see somebody for a while you kind of do notice them, or if you've never seen somebody before. And that's why I think awareness is so important, because if you're aware of the things that can all be put together, like sleep apnea, carpal tunnel, osteoarthritis, dental problems, you can actually say, oh, it's not just a coincidental thing. And the other thing is the issue of public awareness of things that, as I said, you won't notice on a day-to-day basis, but if somebody new sees you, they'll say, oh, do you think, maybe, have you thought about, or are you aware of? So that's the big challenge, is to make everybody, not just doctors who treat acromegaly, but dentists and people who sell shoes and you know, people who do CPAP and people who do sleep issues and sleep studies. Everybody needs to be more aware of this, and that's a hard challenge because you're not focusing on one group, you're targeting so many different people.
Yeah. Dr. Ezzat?
So in line with the news commentary Sunday morning, I will start by saying I respectfully disagree with my colleague. And I will get my son to support me on that. In 28 years that I've been practicing, I see a far more urgent priority issue that is endemic to Canada. What Dr. Asa is talking about is what I call the generic problem that permeates healthcare in general. There's a lot of bad healthcare supply and demand. I don't have a big issue with that, and there can be all sorts of efforts to that regard. I have a much more pressing issue, and that has to do with Canada. We've got a very big country with lots of very dispersed individuals who are scattered all over, and they have the hardest time, much more than in China, as a matter of fact, of getting quality care. It's not a matter of recognizing that it's pituitary disease or acromegaly or Cushing's. These are all hurdles that are recognized, but I have a far more pressing issue when I see people in our country that's supposed to have the highest quality of care across the board getting the worst quality of care. That, in my view, is the most pressing issue, and we need to do something about it urgently, because we can, and I think it is possible. How we're going to do it is largely going to depend on you guys, because you've gone through it. You know what the hurdles are. You know where your missteps have taken place. Think about it. The average GP will have how many acromegalics in their practice? That many. That is the same person you're going to rely on to send you to the so-called expert. So you've got a blind leading the blinder to the end where you will go from one misstep to the next. And that is what bothers me as a healthcare professional and as a citizen, as somebody who really sees this as being a major, major weakness. And I really would like to see something about it done as a priority.
I concur with both husband and wife, so I don't be wearing a left hook. Yes, the awareness factor. We've learned it in mental health. You know, when I say this, nobody else will say it. I don't know why. We should be able to talk about mental health as well in elementary school as we do dental health. It's the dental health that a lot of people, they say, well, Chris, can we pick a better term or whatever? But the reality is that there has to be that general awareness that these types of conditions do exist. And even as with schizophrenia, to be aware of what the prodromal symptoms are, or even the signs before the prodromal symptoms. But I agree then, on the other hand, that the capacity or the lack of capacity, the lack of resources, general practitioners not even being aware, they don't want to treat mental health situations. It's not that they're mean people or anything like that. But yeah, zero knowledge, I suspect, would be even greater with this particular illness group. And therefore, here's my 2 recommendations for you, is number 1, learn all you can about health technology. That is the way of the future for millennials and Generation Z and even some people. And that's in terms of reaching diverse communities, and especially with so much northern territory and space that separates city from city to city. In mental health, we call it e-mental health. So that's just internet technologies and health technologies. And that can facilitate somewhat, I believe, based on education of general physicians about acromegaly. The other thing is, I would say, is what we've learned in the mental health community. I've been at it 25 years plus. We're loud, but we're loud with each other. We're not loud to the people that make policy. So collaborative advocacy. Go to the World Health Organization, and they will demonstrate to you that collaborative advocacy is the way to go. So this dispirited advocacy that we have in our mental health movement currently, it is our greatest holdback of having that centralized, focused message at both federal and provincial level. So as you begin this new organization that you unveiled today, collaborative advocacy.
JD, you want to add to that?
Yeah, thank you. Well, I would say from a communication standpoint that it's about really well-targeted communications to those target audiences that I showed you. If we can find ways to reach just dentists and ophthalmologists, and there are ways to do it, it's just as the broader you get, the more expensive it gets in terms of directories and paid media and those sort of things. So if we had an unlimited budget, obviously we could do a lot more. But it's about getting creative too, and how do we get invited, let's say, to a ophthalmologist conference and do a couple of presentations? How do we talk to nurses? I know Daphne's been working a lot with nurse groups about on acromegaly and about how do we get awareness in those groups. But it's I think narrow, targeted approaches that will spill into the general population with interesting stories.
Okay, great, thank you. So I got Jill, you want to add a follow-on question?
I have a question. How many people in this room were ever told by a physician it's all in your head? By a number of hands. So, I mean, there's quite a few. How come physicians are not taught? I know that they say when you hear hoofbeats, look for horses. But maybe it's not all in the head. They need to start looking for zebras whenever they come to that.
There's been a radical change in medical education in the last 10 to 15 years. We've moved away from experts and knowledge to more of, in fact, they don't even teach medical students now how to perform the physical exam. When was the last time that you went to a physician who actually touched you and knew where your liver was and whether your spleen or your thyroid, or in fact even did your visual field examination properly? We don't do that anymore. There's been a radical change. The system has moved itself away from knowledgeable people and experts teaching students to students kind of learning how to look like they actually know something, but hopefully they will work as facilitators that rely more on patient advocacy. In other words, this is the one time in history where I actually think that we as a public, as those who actually need health services, have to advocate for ourselves. And no one is going to serve it on a platter for us, and certainly don't expect it from the medical community. I hate to say it, but it's true.
So what we've learned in mental health as to that question is that, yeah, it's all in your head because you have a mental illness. And so what we have to encourage physicians to do is not to begin with the question of what's wrong with you, but what is happening to you or what has happened to you. And so the more clearer you can explain what is happening to you as to what you believe is wrong with you, but that's on the shoulder of the physician to not ask a question like, what's wrong with you? You have schizophrenia, but what are the things that are happening to you that are interfering with your life? And their responsibility then to quote, trace it back to some pathology, if you were to say that. Let me say that the hardest thing for a physician to be able to do today, because of wait times, lack of capacity, lack of resources, and the fact that it didn't take appropriate training perhaps in university, is the patient-doctor relationship. So the key person, Deanna, that you want to bring here next year to your conference, and I might help you with a little money. 2 years, okay, is Dr. Shane Sinclair at the University of Calgary, who talks about compassionate care. And he deals with your fundamental question there, is that physicians, as hard as it is, I have a wonderful doctor, a physician, who somehow or another he's able to spend more than 10 minutes with me. And he wants to know what's happening with me, not just what's wrong with me. So Dr. Shane Sinclair from the University of Calgary, Google him. You can read some of his papers in terms of how to have compassionate care. I call it compassionate presence. How to have that compassionate presence so that the issue that you are addressing does strengthen the patient-doctor relationship. Our healthcare system is an unhealthy system currently. All the provinces have the same problem in terms of lack of resource, lack of capacity, the population using the healthcare system in the wrong way, you know, emergent issues as opposed to urgent and so forth. But you know, what brings value to the Acro community, to the Acro voice, to pick up on that. And anyway, that's my answer to that.
Okay.
Can I?
Sir.
Oh. I was just going to say that I think your point is extremely well taken. It's not unique to this group. It's unique to everybody who has a rare disease. I don't know if you noticed, but the Pituitary Network Association actually published a book saying it's all in your head, right? So that comes back actually to what we were saying earlier, and the issue of zebras is not just acromegaly. And I made that comment in my talk that the more people who have rare diseases that are related work together, the stronger the voice will be.
But I have to give the Pituitary Society cheers, because in March, we combined our sessions. We had between 400 and 500 of the top endocrinologists in the world with the 200 and something endocrinologists, acromegaly patients, all in the same place. Mm-hmm. That's how we're going to make change, in my opinion.
I've already been contacted
That's
for
good.
Canada.
Yeah,
But we have
you
to
need to
get it
do that.
implemented.
Okay.
So I actually do have a question that might be able to answer or not. What is with getting a referral every 6 months? Like, we have to go back to the doctor to get a referral to see an endocrinologist that's been treating us for years. Why? Like,
It's 1 year, so.
Well, it depends on the province, I guess. where
we're
you are.
6 months in BC, and it's horrible, and it's time consuming, and it's a waste of time.
It's designed to, it's kind of designed to deter people from access, because they think, the bureaucrats think, just like I mentioned in my talk, that if there's some more treatment or more therapies, that's going to be more costly. Nobody's actually standing back to look at the bigger picture. So it's designed to be an obstacle for you and for the specialists. But you've got to deal with it. And if you have a good relationship with your GP, okay, so it's a very simple fax, and be done with it. I would not let that get in my way. I still maintain, and I'm sorry, I'm perhaps repeating myself, I still think that combining together the unique problems that Canadians, and this is one example of, there's some probably priority issues, recurrent problems that Canadians are facing, that should be a high priority, so that you're addressing them and really prioritizing by groups some of the issues that need to be addressed in the existing population. I'd like to increase awareness, and I want to be able to diagnose people earlier, and I said it in my talk and so forth, but the people who are out there right now really are, I'm very bothered by that.
Okay, good, thank you. So I got a question here from the audience that leads a bit into the patient side of things, and I think it's a very important one. What would any of the panelists think about when you're a patient and you're really down, depressed, or very frustrated with their condition of acromegaly? What should they do, right? Do you have some action items? Do you have some pointers that they get into to deal with that frustration? Because the disease is not going to go away, right? It's not a fixable thing. Chris?
Well, that's certainly a mental health issue, and I think with every condition that we face, first of all, when something occurs to you or happens to you, you come with your preconditioned mental health and resiliency, and you either got it or you don't got it. And so rather than just giving up, and get around people who are secure. We know that in terms of overcoming attachment insecurity, the way you bond in relationship with people, the best way to overcome insecure attachment is to be around secure people. So let's therefore transport that principle. Get around healthy groups that don't pathologize you, but see your potential, that you can move beyond limitations. And then in terms of the depression or the hopelessness and helplessness, everybody needs someone who you can just unload it all, and they will not be judgmental or what have you. So you got to at least have one of those kinds of folks. I think also part of it for some people is finding an avenue for your anger. A lot of anger, frustration with navigating the system, et cetera, et cetera. So find that appropriate avenue where you can do effective advocacy in which you feel like that you're being heard. The problem with advocacy, and with even within the mental health community, and even within the schizophrenia movement, there are so many mixed messages. Again, collaborative advocacy, a consistent one ask message when you go to politicians. And then I think, oftentimes when we look at, let's say that someone is dealing with profound anxiety or depression, we oftentimes will say, well, that's inherently part of the illness or whatever. I have found that whatever emotional pain or brain pain you have will impact on physical or psychological problems that you're having. So taking a very holistic approach to that, to understand yourself. And then also be easy on yourself. I mean, we still... okay, yeah, I mean, that sounded kind of nice, didn't it? Be easy on yourself. But we still live in a world, I think, especially in North America, where there is the normal and the abnormal. We deal with that in mental health. And so your family and your friends, that word would disappear of abnormalities. We're human. We have our conditions, and I think the most fundamental thing in mental health is having the capacity of having hope. I do believe in that concept. I know some people say you can't give other people hope, but I do, and I've had them come back to me and say thank you. So it's a straightforward question, but I will acknowledge it has a variety of answers to it.
So I agree with Chris that learned helplessness, anger, frustration are central and probably the recipe for depression. Trying to deal with it, in my view, at least from my side of medical care, central to that is the level of confidence that you have with what you're doing, with whom you're doing it with. And it gets back to, again, I'm repeating myself. If you're going to a doctor who has to look up the values of what your growth hormone should be, I would be frustrated as hell. So it's no simple matter. Then, of course, you have underlying or what I call organic pathologies. It's not so much, so you've got the disease, you've got the treatment, and now you've got logistics, and you've got ignorance, and all these things are working and stacking up in small little bits that ultimately make it look like you're defeated. So central to all of this is you have to feel very confident about what you're doing and who you're doing it with. And I get back to that same issue of trying to prioritize. Where is the bottleneck? What is that common problem that we have in Canada? And you, by sharing that with each other and identifying very small, immediate steps on how you're going to overcome them, in my view, is the empowerment that's necessary to get across the board to at least eliminate that part of it. There are obviously many other factors, but that is one of the many important elements to get rid of helplessness.
JD, you want? Oh,
I just wanted to make a very brief comment. As a pathologist, I don't do a lot of mental health stuff, but what Dr. Ezzat just said is actually what I think is most critical. You as a group, the people in this room, as patients, know more about acromegaly than most physicians in this country, except for maybe somebody sitting next to me and a couple of other guys here, okay? So knowing that, you should be empowered as a patient group to help each other. And I think that when you get down and when the psychological stuff starts happening, you've got your best allies in the group here. So how do you encourage the communication, which goes to you? So here.
There you go.
Good.
All yours.
Good segue. So what I would say is, like I mentioned, that mental health gets at least 3 times the amount of hits that any other article. And what we've noticed is that sometimes the people that are reacting, it's almost like we've had calls. It's almost like a therapeutic exercise to react to a story and say, here's how it affects me, or this is true for me. And the number of people that respond to it, it's quite amazing to see. We don't share any of the information, but we learn a lot from it. And I can tell you that just when you're speaking to somebody else about it, that understand what knee pain feels like, or being tired and depressed is not depression, but it's important. So.
okay.
Let me add just one thing real quick, okay? What we've learned in the Schizophrenia Society recovery movement, because it's the most devastating of mental illnesses, World Health Organization says, the most stigmatized, is when you get interviewed by the press, do not just give a sorrowful story, because the media will entice you to that, to tell us how bad it is, the pathology and what's wrong, and the hindrances you have in life and the bad things. You have to have people, spokespersons, Deanna, who can talk about what life was before acromegaly, and then what life is like with acromegaly, and then what life is like with the best of care. And that's the point you want to put on it. See, the mission statement of the Schizophrenia Society in 1979, when it was formed by Bill Jeffries here in Toronto, was alleviating the suffering of schizophrenics. All right? Today, the mission statement is helping Canadians living with early psychosis and schizophrenia reach their potential. Do you see the difference in those two statements? So you have potential. Your kids have potential. Pre-diagnosis, diagnosis, post-diagnosis, whatever. And so do not ever let the media characterize you as a hopeless, helpless, deformed, pathetic. You know, that's how the media works. And I don't say the media people are bad, but never mind.
No, thank you, Chris.
Because I do talk with my hook sometimes. I just discovered that today. Here's the thing. When you give a media interview, you don't avoid the question, but you get your message in there. You get the message of hope in there. You get the message of what these doctors have said, that earlier intervention has better outcomes. What a powerful statement that is. If we have early identification, early intervention, you have better outcomes. You don't necessarily go on to develop some of the more comorbidities that we talked about today. That is good news, and that's how you need to do media.
Great. Thank you, Chris. Well, Chris, you said, don't be too hard on yourself. I tell you, my strategy was to be very hard on myself, and it sort of worked. I started climbing mountains. I stopped drinking, which was brutal, but it worked. No, I drink again. I stopped for 7 years, and I climbed Kilimanjaro, I climbed Aconcagua, I started skiing, and it sort of worked.
That's amazing.
It sort of worked. So, you have to be a bit of hard to yourself.
Be a great media person.
Okay, so on to the next question right here.
Okay, this is maybe a little bit out of left field, but I read a study about, it was discussing the use of red light during pituitary tumor surgery. And what caught my eye was in the conclusion that because of the good outcome, the author said it would be worthwhile to research the use of red light with tumors that cannot be resected. And because I'm interested, I haven't had surgery yet, I'm interested in what can be done before that. And I have used red light for the numbness and arthritis in my hands, like diabetic neuropathy, and it's working for that. So I'm wondering if, I put my face into the panel, if that would somehow maybe shrink the tumor, or
Okay.
what your thoughts are on that.
That sounds like a physician's question to me.
So I will confess I'm not a red light expert. In fact, I'm not a light expert at all. But I will tell you this. A lot of times, and perhaps this is of greater interest to other people, I deal with very bad cases, and often patients will come to me and say, I really want to try modality X. And in my view, that we should never discourage that. I may not know anything about it, and in my view, as long as it doesn't cause any harm that I'm aware of, I'm very happy for the patient, because it comes back to what we were talking about before. If you feel that you are empowered because of that, you feel like you're doing something that's making you feel better, that you're engaged, I'm all for it. Doesn't mean it's going to be the only thing, but you're going to do other things as well. I'd rather that you have the right global attitude and that you are in charge of your life and what you're doing, rather than the opposite. I don't care what it is, as long as it doesn't do any harm.
So I just want to make a comment, though, that just to temper that a little bit. We have to disagree. So it's not about disagreeing about this. Based on what you said, it reminded me of something else that is more general. Physicians and researchers have a tendency to overblow their own work. And if you read things in the newspaper, you're going to find every day there's a new cure for cancer, and there's a new test for this and a new something for that. And I sometimes worry, because as physicians and scientists, we know that we publish things all the time, and sometimes we're wrong. Sometimes it worked in one study and not in another, and then when you roll it out to 1,000 patients, it doesn't actually hold out, it was just coincidence. So there are a lot of things in the medical literature that we should be cautious about. In today's world, given the internet and how reliant everybody is on fame and glory and money, everything is always touted like, oh, we've got the new greatest thing since sliced toast. So, I just want to make sure that you're aware that every time you read a study, I'm not saying you shouldn't ask for it. Absolutely, if it makes you feel better, as he said, but always caution on the side of, I've read this, it may be true, it may not be true. If it's not going to hurt you to try it, absolutely, why not? But I just don't like to see people have their hopes and expectations just blown up because the latest, greatest paper said something that may never be reproduced. So we also have to take a little bit of, take everything with a grain of salt, and let's say, here's something that may be promising. Until something's been done 3-4 times in different places by different people, it may not be true.
Great.
Can
One
I
more
just
point
follow
on
up
that?
on
Sure.
that? Because actually, that's a good segue for something that I wanted to talk about a little bit earlier, which again gets back to Canada. If you're a good consumer, what do? You do proper research on whatever it is, whether you're fixing your carburetor or fixing yourself. So when you go to your whomever it is, whatever claim that somebody is trying to sell you, you want supportive information to that effect. In this instance, for example, pituitary surgery is very important. And if you're going to a pituitary neurosurgeon who is not publishing their outcomes and publishing on their complications, how bad do things go in their hands? And if they're not willing to show you that information, whether it's the neurosurgeon, the radiation oncologist, or the medical physician such as myself, with the medications, you need that to be able to research it properly to satisfy yourself, whether it's red light, surgery, radiation, or any other treatment. And that's how you will get to know as a consumer whether you're really in the right place or not.
Okay.
Instances where a tumor has regressed?
I can tell you for certainty that tumors can regress spontaneously without doing anything. And that happens as they generally outgrow their own blood supply. They undergo what's called necrosis. So you got to be very careful again. And that's one of the things that we have to be very wary about. Whether I'm publishing a paper or I'm reviewing a paper, I need to know what the background natural history of any condition so that I know really what is or is not a treatment-related effect.
Okay. Time for the next question.
So just quickly about alternative complementary orthomolecular medicines. My wife is very dedicated to that, and she had breast cancer 2 years ago, and that's the therapeutic route she went. She's in remission and et cetera. But what I had to caution her about was if you go to the end of the website and they're trying to sell you something, all right, it's suspicious to me. And if they make these grandiose statements that every one of their patients has gotten healed or whatever, forget it, okay? I'm not against orthomolecular alternative medication. Some people do have anecdotal successes at it. We just need a lot more research around that, though pharmaceutical companies are against it. But it's a word of warning. Because we're all looking for hope. We're all looking for that miracle, okay? But that's just some words of wisdom about the cautionary aspects.
Good. Next question is right in front. Your hand has been up for quite a while now, so Jennifer, I think, right?
Yeah. Hi.
Hey,
Thanks for
wait,
being here.
hang on. We need to be able to hear this in the video.
Okay, yep. Okay, thank you for coming, everyone. So I have a few points, JD, just about your website. You're asking something that you think that might be helpful. I feel like your website, just in looking at it, is maybe a little too, has a too serious tone, and maybe it needs to be more kind of, because I feel like it's geared more to professionals than I say the average user. I thought maybe that it looks too serious, like journal articles. Yeah, so I thought maybe if it's sometimes like stuff that's more poppy and like is and easier accessible. But I just want to ask you guys a question. In the last year, I have to like give a little anecdotal speech about it, but in the last year I was in a university program. I was doing my master's in a child psychology program at the University of Calgary, and I got sick for about a month and started to get all these weird things with me, and this was before I was diagnosed with acromegaly. And my thesis advisor said that I wasn't sick enough to miss class, and I eventually got kicked out of the program there, and I got a bunch of Fs on my transcript. And I've heard a little bit today that sometimes in the interim that acromegaly can really affect like your work, your personal life, clearly like my school life and my future career endeavors. And like, I'm not a person of wealthy means. To get a lawyer and go after them like in a lawsuit is quite difficult. I'm wondering like how we can advocate human rights, because it is like a disability and it does affect. And again, that goes back to Jill's point that it's, you get told it's all in your head, or there's nothing wrong with you, or you look fine, or your blood works fine. And I'm just kind of, I don't know where I'm kind of going with that, but I just think that maybe that needs to be broadcasted more. And one other thing that I wanted to say was, I think that doctors never want to say when they don't know what they're doing. So I think that's a huge barrier to us here. Like they should say like, no, I'm the person who, my endocrinologist wanted to like look up my growth hormone levels after my glucose intolerance test, and she shouldn't have to do that, right? She should have told me, I don't know, I want to refer you to somebody else who's more specialized. But I know that's a lot in a small amount of time, but yeah.
Okay, I hear two things. One is sort of acromegaly can be seen as a disability and affects your sort of employment position or when you're at university. So that's one piece, and the other piece is sort of how to communicate with your doctor. And if a doctor doesn't know, he or she should actually make that explicit and refer you to another address, right? Is that
like doctors are too egotistical to say, hey, this is out of my specialty area.
okay? Who wants to take on any of these two questions?
I'll answer first. So thank
JD.
you for the comments, because we're always learning about how to do things better. And I think you're right that we could be lighter and sometimes it's a little more difficult. But one of the problems is that we have a lot of the lighter stories that get buried by the other ones, because they're the ones that people go to, and the program itself sort of brings to the top the things that are getting hits.
But you can have a tree where you can have
Yeah. Yeah, and I think that's probably going to happen. We've been thinking about that. But we have some interesting light things that are probably, there's about 450 articles and about 70 podcasts. So it's difficult to get, and they're all relevant. So how do you get them all in the front page? But I thank you for the comment, because I think you're, no.
I meant like your design.
Yeah.
Design, like even your use of text, that kind of stuff.
Yeah, it could use, yes, absolutely. I'm the designer also of the thing, so, and I have no idea what I'm doing, other than it's a good template. So, yeah, so we can always use a good designer, absolutely, no doubt.
Okay.
Thank you.
Dr. Asa.
So I'll just make a comment about your point about physicians. Again, I would empower you to go back to your doctors, because I'm sure every one of you has had either a family, like a primary care physician, or somebody that you were going to for many years when they didn't make the diagnosis. And there's nothing more powerful than having you go back to a person who missed it and say, this is what my experience was with you. You missed it. It's rare, but it's not that rare, because I'm here, and you may have another person like me coming through your door any day. You need to understand that these are manifestations that we know are subtle, and yes, it's rare, but now you should be familiar with it.
Okay, so several things. There's a great accessibility movement happening at the federal and provincial levels, especially at the federal level currently, and some subsidies and funding, Deanna. So you want to include yourself as an accessibility community in terms of whatever impairments or disabilities that you have in terms of workplace accommodation, public place accommodation. So make your issue as to what that looks like and means to you. It's been very challenging for those of us in mental health, because it's hard to see mental health as sometimes being a accessibility or disability issue. The second thing is utilize the UN Convention of Rights of Persons with Disability. Canada is a sign-on nation to that, all right? So know that legislation, use it. The third thing is psychological health and safety in the workplace. So the Mental Health Commission has done a lot, and it applies to, it's not limited to mental health. I mean, whatever accommodation you need in the workplace, the Human Rights Commission, the different provincial human rights commissions say the number one complaints they have are complaints around people who have impairment or disability associated with some sort of mental or physical challenge. And then the fourth thing, finally, is do you know about CADATH? CADATH. All right, so you know about CADATH, and CADATH has the Common Drug Review. The Common Drug Review. Well, you know what? They never give you the full name of the initials. Well, okay, it's an arm's length government-funded organization. I can't find what the initials mean, but it's just called CADTH, and it's about doctor and patient relationships and getting more input from patients. So they have a conference every year, and so patient input. Under CADATH, when Health Canada approves a medication, then it goes to the Common Drug Review. Now, I may have that a little reversed. They can correct me. So the Common Drug Review then is where you have input as to what kind of medical interventions, there'd be something else, not just medical, but health technologies. Health technologies that you as a community want to be prioritized. So as a national organization, these are some of the things that as a national organization you can advocate for.
Okay, so we're at the 4:30 mark, so I want to accommodate one more question before we go over to the group photo. So you had your hand up for quite a while. Well, we'll do two more questions, and then we're done. Okay.
All right, very quick. Quality of care, and I agree with you to a degree. I'll argue with you that. I'm from the Northwest Territories. I had a very good physician. I went through braces, restless legs, and I went to a clinic here in Toronto, sleep studies, carpal tunnel, sleep apnea. I had a left hip replacement. Everything was addressed. All of those were addressed until the thyroid, where my father passed. Don't they have some kind, like, can a doctor see after 5 or 6 you connect them? Like, don't they see that on your records?
That's a great question. Yeah.
Like, because everything is there. Like, and he's not an idiot. He's a good doctor. And when they finally told me, I texted him. He said I didn't have a clue, but everything was there.
Everything was there.
But do they not have a database when they put your records in? It's after 3 or 4 hits. Check
Should
this.
be. So, you want to take that on that question, or? Yeah.
You know, the part that makes me as a specialist feel very helpless is exactly that. To be honest with you, I wish this was rocket science, and I wish this was a difficult condition. I deal with a lot of very complex disorders, and I have to confess, acromegaly is probably the simplest and easiest for me. That's the sad part. Can you imagine? And this is why I guess I keep harping on the same point here is, if this is one of the simplest, can you imagine about the more complicated ones? Think about it.
Great. Okay. One more question. The question was over there.
And I got one over there too, so I'm just gonna go. I do have to say though, it's gonna take you guys to get to the GPs at their conferences to bring this to their attention. We need you to get to their conferences and make this knowledge implanted in their brains, because the GPs do not think outside the box. Okay.
I'm going to put it out there. I'm going to say that the bottleneck, quite honestly, is in the medical schools that have become garbage. Absolute garbage. We have deans of schools of medicine in Canada right now that represent the lowest of mediocrity. And I will say it out public. We have deans that know very little about medicine, that get to the very top, and from there we have the worst level of education. It's not a matter of a GP, it's a matter of, if you don't start off the right way, knowing that you need to be intelligent enough to do the most simple things, like you've said, just read the chart and look at things. You don't have to be an Einstein to figure that diabetes, hypertension, sleep apnea means something. It doesn't matter what it is, but at least know, get off your ass and figure it out. And if you don't, send it to someone who does.
Thank you. That was very clear. Last question for today.
Yeah, I don't really have a question per se, and this is more directed to the organizations. I have a problem with the federal government, and more specifically with the tax disability credit. Like most people here, I suffer from a litany of problems. Virtually every psychological problem, every physiological problem I have suffered with. Right in the beginning when I took the sandostatin, and the combination of that and the acromegaly gave me severe bilateral Meniere's. I have no hearing in my left ear, only partially in my right. I lost my job. I lost my licenses because of peripheral vision problems. I can't pass a test. My body is being consumed by arthritis. I've had the hip replacement, shoulder replacement. Got to do the other side. I have to have 4 more serious operations within the next 3 years, and I cannot get the tax disability credit. They say you have to be 90% blind. Well, okay, I'm 65% blind. They say you have to be 90% deaf. Okay, well, it's like 70% deaf. When you add up all my percentages, there's like 1,000%, not 90%. And if the federal government is not going to take acromegaly seriously, well, what's the point? My wife actually had to quit her job to take care of me because of all my problems. It's cost us hugely, like for pensions and everything else. And they don't seem to think that, acromegalies are worth the disability tax credit. So if they think I'm willing to sacrifice tens of thousands of dollars so that I can get a crappy $1,000 rebate on my income tax, I would like the organizations to inform or re-educate the government on, as you say, we have an accumulation of problems, a commodity of problems, and I'm angry. I paid taxes for a long time, and now when I actually really need help, the government is not there.
No. Well, what I can say is...
There is an organization that was created many years ago, and it's the CPPN organization, Canadian Pituitary Patient Network. They are the organization that was created to help tackle those problems. So if you get a chance to reach out to them and chat with them, they could probably give you some guidance. They're about 2-3 years in now. As just starting up with the national, we'll get there, but it ain't gonna happen fast enough for you to what you need right now. Does that make sense? Okay, so reach out to them, but the doctors might have a quick.
Well, Diana, you may want to add, you have great relations with a member of parliament, right?
All right, so we've known that in the past year and a half that CRA has been denying hundreds of thousands of people who have been receiving disability tax credit. Why all of a sudden in the last 2 years they are rejecting people like people with schizophrenia? The Diabetes Association has pointed this out. So there is a national organization, Deanna. It's called the Disability Tax Credit Alliance. It's run by Limby Buchanan. It's made up of about 26 national organizations in which we're working with the current federal commission. You may know the name of the current, that the CRA or the minister, I can't forget, it's French word. But anyway, and it has just been a challenge to try to get them to understand that how do you measure 90% disability in terms of a mental health situation, okay? So the disparity, the inequity, the injustice of all of this. So get to know the Disability Tax Credit Alliance, and the leader is Limby Buchanan. Email me, I'll put you in touch with her.
I'll just mention very briefly, the disability forms that go to the federal government require specifically at least 2 physical, not mental, they don't actually count. So they require 2 physical, and they categorically request from the physician to be able to say, how frequent is this disability? Occasionally, sometimes, or all the time, most of the time. And then the next question comes, is it expected to remain the same, get better, or get worse? So how those forms are completed by your physician, I would argue, is so important that I would recommend to you that you review those forms after they're completed and you send it yourself so that you know that it is accurate, and if it's not, you reconcile it with your physician.
But you're going to get more results. Sorry, I'm so sorry I'm going to do this to you. You're going to get faster, better results if you have your endocrinologist fill out those forms.
If it's an endocrinologist.
I agree. You know what? I honestly, Deanna, it has to be somebody who is familiar enough to be able to fill it accurately enough and detailed enough with supportive documentation. That's why I say you should be the one sending the completed package so that you know what went into it and what is missing. And I got to tell you, a lot of times I make a mistake and the patient send it back to me and I do it all over again. And I'm happy to do it because I know how it impacts you.
Good.
He's absolutely right. Don't depend on the doctor's ability to fill out that form correctly because it's hard as hell to begin with.
Okay. JD wanted to add something to that, right?
We are done with this because I wanted to say something about what you had said.
Last
about
point, and then
medical
we're going to wrap
schools.
up.
So I work with UC Berkeley on a program that they have with UCSF, and I've been doing presentations to medical students for about 5 years. They're usually 15, 20 kids in each, so it's a tiny bit. But I will promise you that none of those kids are ever going to miss a case of acromegaly. They do a case study, and I'm the the guinea pig, and it's really I promise you it's one of the funnest things I do. Those kids are open-eyed, and when you walk, you feel like a celebrity walking into this medical school because they just want to learn. And I think we've been working on an idea to put patients in medical schools and do it in a way so if I'm hoping we can do it worldwide, because they study a case study on acromegaly and then they get to meet somebody with acromegaly and you get to answer questions and they really learn. So I always tell them, regardless of what you do after you graduate, what specialty you go into, if somebody with acromegaly walks into your office, you're not going to miss it, I promise you.
And instead, I just have to add this, instead what we do, and not us, but the medical schools teach people that acromegaly is rare, you'll probably never see one. And that to me, I mean the difference between what you just described and what goes on in most medical schools, he's absolutely right. And that's why I said before, you go back to your physicians too, because your GPs who missed it, they were all taught they're never going to see this. You go back and tell them, you missed my diagnosis, they'll never miss another one.
I will tell you that my physician, who missed it for almost 20 years, I had a very serious conversation with him because he's a good friend. And 2 months after I was diagnosed, actually about a year and a half after, I get a call from him and says, you know what? I just had a patient that came in, his son came into my office and I just diagnosed him. I sent him over to get an MRI. And I said, you made my day. You
Okay.
made my day. And I actually met, thank you. Yeah.
Okay.
I met the gentleman, and he was actually operated and cured. So he will never miss another case. I promise you that.
Well, on that note, I think we're going to wrap up.